Okay, so very good afternoon, everybody, and a very warm welcome to today's webinar. Very important topic from a cardiology point of view, pediatric cardiology. So, commonest problem is the acyanotic heart disease, and that are the shunt lesions. If treated on time, excellent outcome. If not, obviously, we have very grave prognosis. So, this is a very important topic to be discussed by Dr. Rama. And I request Dr. Neeraj. Neeraj is chairperson. He is senior pediatric cardiologist at Gangaram Hospital, and Dr. Anuj Rastogi. So these are the chairperson for today's talk. I request Neeraj to introduce Dr. Rama, and then we'll go ahead with the presentation.
So very good afternoon, all the chairpersons, all the speakers, all the dignitaries of IAP. And we welcome Dr. Rama sir. He's a professor of cardiology. And in pediatric cardiology, everyone knows him. He has publications in every part of pediatric cardiology. Special interest in PH, as I understand, he takes a lot of interest in PH and shunts. So operability criteria, we talk to him whenever we are confused about operability criteria, we talk to him. He's an eminent speaker, and you know you will find lot of publication, maybe around 350 publications in his name, and lot of articles and YouTube channels showing videos explaining about heart disease. So we welcome him, and I think we can carry on as ma'am says.
Thank you, Dr. Munesh, Dr. Neeraj, for such a warm introduction. I am sitting in a conference, so maybe there may be some voice disturbance may be there. Apologies for that. So today we'll be discussing about one of the most important lesions, that are the left to right shunts. And these lesions and the various important cyanotic congenital heart disease like TGA and TAPVC, if all of them are operated in time, we will have a absolute reduction of maybe around 2 to 3% in the under 5 mortality easily. So both infant mortality and under 5 mortality can decrease if we operate these patients in time. So what is left to right shunt? So left to right shunt is the communication between any part of the pulmonary and the systemic arterial circulation. Any of the left side of the heart and the whole circulation, the right side of the circulation is called left to right shunts. They are characterized by excess flow from the systemic, from the left side to the pulmonary circulation, which is on the right side. So this is a simple schematic diagram that says, okay, the SVC return comes.
We can't see the slide. I think you have to share the slides.
You are not able to see the slides?
No, from my side I can see it clearly. No issue. Audible and visible.
Okay, so maybe something from my side.
Okay. Check from your side. Yeah.
Please continue.
Okay. So it's a very simple schematic diagram for everybody to understand. So there is a systemic venous return that comes into the right heart. That is a pulmonary blood flow that goes into the lungs, which is generally a low pressure circuit and a very highly compliant circuit. So the simple thing about highly compliant circuit is that the moment you run, a significant exercise is able to do. So the lungs are able to accommodate at least 6 times the blood flow without increase in pressure. That is how compliant they are. So from there, the pulmonary venous return comes with the left heart, and that goes into the systemic blood flow, which is a high pressure and a low compliance circuit in relative terms. So this is a simple schematic diagram. So what is going to happen in left to right shunt? At some part of the heart, or maybe at times outside the heart, so things can start to happen like, so there is a shunt communication from the left side of the heart to the right side. So the pulmonary blood flow is not only the pulmonary blood flow, that is the right side flow that is coming in, but also the left to right shunt is getting added here. So this is a classical simple schematic diagram to explain what is a simple left to right shunt. So what are the consequences? So simply said, the pulmonary blood flow is increased. So more blood is coming from the left side of the heart into the right side, either into atrial level or in the ventricular level or at the pulmonary artery level. So hence the pulmonary artery blood flow is increased. So depending on the shunt location and the quantum of the shunt and the age of the patient, the pulmonary artery pressures is elevated. So consequently, the lung mechanics are altered, the cardiac chambers are volume ordered. So what happens? Suppose if there is an atrial septal defect, you go back to this diagram. If there is an atrial septal defect, left atrium, the flow is coming into the right atrium. So there is right atrial enlargement, there is right ventricular enlargement, and then there is PA enlargement. Then all these structures within the shunt circuit get enlarged. So that's a very simple thing to understand. Whatever is there in the circuit, all the chambers are enlarged. So there is neurohumoral activation that happens and there is fluid retention that happens, leading on to heart failure and then failure to thrive. So all left-right shunts are not the same. So not all are symptomatic, not all are hemodynamically significant. So definitely not all require surgical or interventional shunt. So fundamentally, these shunts can be differentiated into, for our understanding, can be differentiated into those happen before the tricuspid valve, those happen after the tricuspid valve. The importance being that atria, for example, you can easily understand the pressures here. Atria will have a pressure of say 5 and 10, whereas ventricles will have a pressure of say 120 or 100 in a child, LV. So RV also will have say 20 pressures, but then the moment there's a large hole, the post-tricuspid shunt happens, the pressures also become high in the RV side. Whereas atria is going to be 10, becomes, even if it's unrestricted ASD, the RA is going to become 10 only. So fundamentally, immediately upon a large post-tricuspid shunt, not only there is a volume overload, but there is also a significant pressure overload. So it's very simple to understand. The moment a large VST is there, that means the RV pressure is going to be, RV systolic pressure is going to be a systemic pressure. So clearly, not only there is a left-to-right shunt in terms of volume, but there is also significant pressure overload on the right side of the heart. So in general, you have in a pre-tricuspid shunt, that is something that is happening before the tricuspid valve. The common garden varieties will be atrial septal defect and the partial anomalous pulmonary venous connection, the PAPVCs. So there, what is going to happen is the lower RV and PA pressures are there, and the lower LA pressure is there. That leads to dilated RA and RV. Symptoms are generally late onset and generally mild in nature. Whereas if you look at the post-tricuspid shunt, the shunts can happen at the ventricular septal defect level, or the atrioventricular septal defect level, or aortopulmonary window, AP window, or patent ductus arteriosus. Here, the pressure is also transmitted, as I repeatedly emphasizing. So there is a higher RV and PA pressure, there is a higher LV pressure, dilated LA-LV, and then the early onset and severe symptoms ensue. So important point that we have to understand is the defect is congenital, but the shunt is not. So the left to right shunt establishes only after fall in PVRI. So I just have one question I'm asking. So at what age does a VSD become inoperable? Is it 1 year, 2 years, 5 years, or 20 years? So maybe I think we can put it to poll, and you can just scan this QR code and put your answers here. So simple question: at what age of a patient a common garden VSD becomes very likely to become inoperable? What is the kind of a cutoff that we all should have it in our mind? So you can just scan the QR code and then the question will come and then you can all start voting.
It's taking time. I'm just scanning, taking time. So we have to give some time. Okay. Yeah.
Yes.
So I think this is a typical trap question that I think we all understand, and then there is a possibly a lack of understanding and lack of communication from our side also. So most of the VSDs that are very large become inoperable by 2 years of age. The correct answer is 2 years. Even though the patient may come and present to you with symptoms of Eisenmenger by around 20 years of age, that is a totally different thing. So all large VSDs must be operated before 1 year of age. So it's a kind of a process. The operability, inoperability is kind of a process. So most of the large VSD will become inoperable by 2 years of age. So all the pediatricians should be mindful of that. No large VSD should be said that, okay, it will may close over time, so we can wait and watch. So that is the most important message that I want to convey.
Yeah,
At some times,
we should also convey that the process start before at 6 months of age. So,
Yeah. I'm coming to
yeah,
that now. I'm coming to that later. This is just to get them in that, okay. So by 2 years, it's the window of opportunity ends at 2 years, but it actually starts at around 6 months, 1 year of age, and sometimes, rarely, in Down syndrome, in patients with some other congenital anomalies, or in patients with upper respiratory tract issues, they may become inoperable by even 1 year of age. That is, you have to keep in mind. So we'll come to that in detail later when we discuss about VSD. So in all the shunt that we discussed about, the immediately after birth there is a substantial reduction in pulmonary vascular resistance that we all know, and then later on it comes to the adult level. But in a PSD, it may never fall. Actually, there is a failure to fall of the PVR, and then this is when most of the VSDs start presenting. So the second most important take-home message is most of these left to right shunt don't present with symptoms before 6 weeks of age in general. In general, but there could be exceptions. But then when there is an exception, you have to absolutely rule out valvular lesions, obstructive lesions like associated MS, associated coagulation, or aortic stenosis association. All those things you have to rule out. But PDA can present very early, but then later on, most of the VSDs and ASDs don't present before 6 weeks of life because there is no shunting. The PVR is so high that there is no shunting happening. So that is what the important thing. So coming to clinical presentation wise, when do you suspect a left to right shunt? So typical simple thing is overfeeding, cycle with the failure to when the baby is sucking, and then immediately there is forehead can be perspiration, sweating in the forehead. There is failure to thrive, and then recurrent lower respiratory infection can be there. So oftentimes nowadays, based on some other clinical picture like murmur, associated findings, or suspicion of heart disease is auscultated and then found out. Oftentimes, it is nowadays picked up from X-ray, which is routinely done to rule out uh, uh, pneumonia or something. Then suddenly you find cardiomegaly and the patient is referred to a cardiologist. But the patient may be asymptomatic if there is QP by QS, that is the pulmonary to systemic flow is 1.5 to 1. That means so 100 ml is going into the systemic circulation, 150 ml is going into the pulmonary circulation. That is this 50 is the extra left to right shunt. So the patient may be asymptomatic, and then there is a pre-tricuspid shunt like ASD also. The patient may be asymptomatic. So clinical presentation wise, patient may be asymptomatic in ASD or VSD with PDA, especially if the shunt is lower, or incidentally directed murmur are generally ASD, VSD, PDA with the shunt is lower. Poor feeding and failure to thrive and recurrent LRT and heart failure are typical of ASD, PDA, and AP window. They are the ones that typically produce. Very rarely, infants with ASD may also present with heart failure and failure to thrive. So by and large, the take home message from all this is that generally by 6 weeks they don't present. And by 6 weeks to 6 months, the process of operability, the window of opportunity is the best. So beyond 6 months, you are actually tossing a coin. By 1 year, the process is almost maturing, and by 2 years, they become inoperable. We are talking about mostly post-tricuspid shunt. That includes VSD, ASD, and AP window. AP window can become Eisenmenger early.